Good morning, class. Today we'll be going over Chapter 10, Airway Management. So, airway management, respiration, and artificial ventilation applies knowledge of general anatomy and physiology to patient assessment management in order to assure a patent airway, adequate mechanical ventilation, and respiration for patients of all ages. So, airway management. You need to know your airway anatomy, airway assessment, techniques of assuring a patent airway. Respiration, anatomy of the respiratory system, physiology and pathophysiology of respiration, pulmonary ventilation, oxygenation, respiration, external, internal, and cellular. Assessment and management of adequate and inadequate ventilation, supplemental oxygen therapy, assessment and management of adequate and inadequate ventilation, artificial ventilation. Artificial ventilation, a minute ventilation, alveolar ventilation, effect of artificial ventilation on cardiac output. Pathophysiology applies fundamental knowledge of the pathophysiology of respiration and perfusion to patient assessment and management. Primary component of caring for patients is ensuring that they can breathe adequately. First thing you do when you come on scene, part of your primary assessment is making sure they have an airway. Make sure it's open and make sure that they can breathe. When the ability to breathe is disrupted, oxygen delivery to tissues and cells is compromised. Vital organs may not function normally. Brain tissue will begin to die within 4 to 6 minutes. So patient's airways isn't open. That's a serious issue. We need to make sure that it's open and we can breathe for them if the patient's not breathing on their own. They can be in respiratory failure or respiratory arrest. Oxygen reaches body tissues and cells through breathing and circulation. During inhalation, oxygen moves from the atmosphere into the lungs. Oxygen-enriched blood is pumped through the body by the heart. You must be able to locate the parts of the respiratory system and understand how the system works. So, picture the airway. Remember, we talked about where's the upper airway and where's the lower airway. Okay, so anything above the larynx is going to be upper airway. So nasopharynx, oropharynx, epiglottis, mouth, and then trachea, bronchioles, and your lower airway, and pulmonary capillaries over here, alveoli. So your trachea goes down and breaks off into two, right and left bronchi. Okay, and when it breaks off, the carina is the anatomical term for it. The respiratory system consists of all the structures that make up the airway and help us breathe or ventilate. The airway is divided into the upper and lower airways. Structures that help us breathe: diaphragm, chest wall muscles, accessory muscles of breathing, nerves from the brain and spinal cord to those muscles. Upper airway consists of nose, mouth, jaw, oral cavity, pharynx, and larynx. The upper airway's main function is to warm, filter, and humidify air as it enters the body. Pharynx, muscular tube extending from nose and mouth to level of esophagus and trachea. Composed from top to bottom of the nasopharynx, oropharynx, and laryngopharynx. Nasopharynx filters out dust and small particles, warms and humidifies air as it enters the body. Oropharynx, posterior portion of the oral cavity, entrance for respiratory and digestive system. The epiglottis is superior to the larynx. So your uvula back here, you got your tongue, and your epiglottitis. This is going to be covering your trachea. So your larynx, complex structure formed by many independent cartilaginous structures, marks where the upper airway ends and the lower airway begins. So remember, this is Adam's apple, right? Cricothyroid membrane. For paramedics, they could do they could open up this airway if it's blocked as a last resort. Larynx, thyroid cartilage forms a V shape interiorly. Cricoid cartilage forms the lowest portion of the larynx. Glottis is the area between the vocal cords. The lower airway's function is to deliver oxygen to the alveoli. Lower airway includes trachea, bronchi, and lungs. Trachea, conduit for air entry into the lungs, divides at the carina into two main stem bronchi, right and left. Bronchi are supported by cartilage. Bronchi distribute oxygen to the lungs. So here it is again. So you got your trachea, and your carina breaks off into right and left. And your alveoli is over here. And your bronchiole, it breaks off into smaller bronchi. And then it eventually becomes bronchioles. Bronchioles are made of smooth muscle. They dilate and constrict as oxygen passes through them. Smaller bronchioles connect to alveoli. Oxygen is transported back to the heart and distributed to the rest of the body. The heart and the great vessels, vena cava and aorta, are found in the thoracic cavity. Okay, so blue, remember, it's going to indicate deoxygenated blood. It's carrying blood to the heart to be oxygenated. So you got your, remember what it's called on top? It's going to be superior vena cava. It brings blood from the top of the body down to the heart. And this is going to be your inferior vena cava. Brings blood from the lower part of your body up to the heart. The aorta. So this is red. That's oxygenated blood, correct? Okay. So that's what blood comes out. The oxygenated blood goes out into the aorta and goes to other parts of the body. And this is just a picture of the respiratory system, how the diaphragm works. The mediastinum, the space between the lungs, contain heart, great vessels, esophagus, trachea, major bronchi, many nerves. Physiology of breathing. The respiratory and the cardiovascular systems work together. Ensure a constant supply of oxygen and nutrients is delivered to cells. Remove carbon dioxide and waste products. So these are important terms you guys should know. Ventilation, the physical act of moving air into and out of the lungs. You guys have all seen TV shows where they're on ventilators. They're pushing air into and out of the lungs. Oxygenation, the process of loading oxygen molecules into hemoglobin molecules in the bloodstream. Respiration, the actual exchange of oxygen and carbon dioxide in the alveoli, as well as the tissues of the body. Make sure you know which ones these terms are. So ventilation, physical act of moving air into and out of the lungs. Inhalation, active, muscular part of breathing. The diaphragm and intercostal muscles contract. The lungs require the movement of the chest and supporting structures to expand. Partial pressure, the amount of gas in the air or dissolved in fluid. Oxygen and carbon dioxide both diffuse until the partial pressures in the air and the blood are equal. So inspiration focuses on delivering oxygen to the alveoli. Tidal volume, dead space. Exhalation does not normally require muscular effort, passive process. So remember, inhalation is an active process. Exhalation is a passive process. So when you're exhaling, you're not exerting much activity. Diaphragm and intercostal muscles relax. Smaller thorax compresses air into the lungs. Exhalation, air can enter and leave the lungs only if it travels through the trachea. So air can only enter and leave once it goes through the trachea. So this is important why we keep a patent airway. So we get air into and out of the lungs. And people could breathe. Regulation of ventilation involves a complex series of receptors and feedback loops. Failure to meet the body's needs for oxygen may result in hypoxia, based on pH changes in the blood and cerebrospinal fluid. Patients with COPD have difficulty eliminating carbon dioxide through exhalation. Oxygenation, process of loading oxygen molecules into hemoglobin molecules in bloodstream. Required for internal respiration to take place. Does not guarantee that internal respiration is taking place. Ventilation without oxygenation can occur where oxygen levels have been depleted. E.g., close encounters. And so mines, confined spaces. Respiration, actual exchange of oxygen and carbon dioxide in the alveoli and tissues of the body. Cells take energy from nutrients through metabolism. External respiration, pulmonary respiration, brings fresh air into the respiratory system, exchanges oxygen and carbon dioxide between alveoli and blood and pulmonary capillaries. So remember in the lungs, I was telling you. So veins are carrying deoxygenated blood in the body. In the lungs, they're carrying oxygenated blood. So you got your pulmonary. Pulmonary means lungs. Pulmonary arterial, it's blue, so that's deoxygenated blood. Arteries normally carry outside the lungs is oxygenated blood. So remember, it's reversed in the lungs. Internal respiration, exchange of oxygen and carbon dioxide between systemic and circulatory system and cells. Eventually, all cells will die if deprived of oxygen. So, time is critical. If you see an airway problem, you need to fix it. So, 0 to 1 minutes, cardiac irritability. 0 to 4 minute, brain damage, not likely, but 4 to 6 minute, brain damage possible. 6 to 10 minute, brain damage likely. More than 10 minutes, irreversible brain damage. So, you want to try and fix something as soon as possible, at least. Hopefully before the 4 minute mark. Pathophysiology of Respiration. Factors in the nervous system. Chemoreceptors monitor the levels of oxygen, carbon dioxide, hydrogen ions, pH of cerebral spinal fluid. Provide feedback to the respiratory centers. Ventilation perfusion ratio mismatch. Air and blood flow must be directed to the same place at the same time. Ventilation and perfusion must be matched. A failure to match is a cause of most abnormalities of oxygen and carbon dioxide exchange. Gas exchange does not take place. Lack of O2 in bloodstream. CO2 is recirculated within bloodstream. Severe hypoxemia can occur. Factors affecting pulmonary ventilation. Maintaining a patent airway is critical. Intrinsic factors. So within the body. Infections, allergic reactions, unresponsiveness, tongue obstruction. So allergic reactions, what happens is it's a defense mechanism. Something foreign attacked the body. So what happens when you have an allergic reaction is your bronchioles constrict. And you start having trouble breathing because you're not getting enough air in. So extrinsic factors, outside the body, trauma, foreign body, airway obstruction. Factors affecting respiration, external factors, atmospheric pressure, partial pressure of O2. So you guys have been in the mountains before. As you guys go up in elevation, the air gets thinner, so it gets a little tougher to breathe. Internal factors, pneumonia, pulmonary edema, COPD, emphysema. Circulatory compromise. Trauma emergencies typically obstruct blood flow to individual cells and tissues. Pulmonary embolism, simple or tension pneumothorax, open pneumothorax, hemothorax, hemopneumothorax. Other causes, blood loss, anemia, hypovolemic shock, vasodilatory shock. Okay. Patient assessment, recognizing adequate breathing. For an adult, remember it's between 12 and 20 breaths a minute. A regular pattern of inhalation and exhalation. So regular is key. If it's irregular, you probably have to step in and start helping the patient breathe by either ventilating them with the BVM or giving them oxygen. Bilateral, clear, and equal lung sounds. So check both sides of the lungs. Just because one side of the lung sounds clear doesn't mean the other side of the lungs are going to sound clear. Regular equal chest rise and fall. Adequate depth, tidal volume. So recognize abnormal breathing. Fewer than 12 breaths a minute. More than 20 breaths a minute. Irregular rhythm. Diminished, absent, and noisy auscultated breath sounds. Reduced flow of expired air at nose and mouth. Next time you guys are sick, next time you guys have a cold, you're coughing up mucus, listen to your lungs. What does it sound like? Listen to your lungs when you don't have a cold. So you guys understand the difference between clear lung sounds and lung sounds that have bronchi. Or if you have a friend who's got asthma and they telling you they're wheezing, go ahead and listen to their lungs real quick. So unequal or inadequate chest expansion, increased effort of breathing, shallow depth, skin that is pale, cyanotic, cool or moist, skin pulling in around ribs or above clavicles during inspiration. A patient may appear to be breathing after the heart has stopped, called agonal gasp or respirations. Cheyne-Stokes respirations are often seen in patients with stroke or head injury. So irregular breathing. This is kind of their breathing pattern right here. They start breathing, and then they stop a little bit, and then they start breathing again irregularly. Kind of shallow, not really breathing, and start breathing again. So ataxic respirations. Irregular or unidentifiable pattern. May follow serious head injuries. Kussmaul respirations. You guys are probably going to see this a lot more out in the field. Deep, rapid respirations. Common in patients with metabolic acidosis. So these patients are going to be diabetic patients. Patients with any high blood sugar are probably going to have Kussmaul respirations because they're trying to breathe off all that excess sugar in their body. They're going to kind of have what we call fruity tone breaths. They're going to smell like fruity gum almost. Patients with inadequate breathing need to be treated immediately. Assessment of respiration. Even though the patient may be ventilating appropriately, respiration may be compromised. Level of consciousness and skin color are excellent indicators of respiration. Remember I said treat your patient, not the monitor? Just because the monitor might tell you something good, look at your patient. Look how they're breathing. Look at their level of consciousness, their skin color, and see if they're breathing adequately. Is it regular? Is it equal chest rise and fall? Are their lung sounds clear bilaterally? Also consider oxygenation. Pulse oximetry is considered a routine vital sign. Can be used as part of any patient assessment. Opening the airway. Emergency medical care begins with ensuring an open airway. Rapidly assess whether an unconscious patient has an open airway and is breathing adequately. Position the patient correctly. Supine position is most effective. So if you have a patient who's prone, face down on the ground, you're going to have to log roll them. And what do you want to do when you see a patient on the ground? You want to check their back first before you roll them over and have someone to hold the head if you think it might be a trauma. So how are you going to open the airway if you think it's a trauma? Jaw thrust maneuver, right? If it's a medical, you do head tilt, chin lift. If you're unsure, do jaw thrust. Always err on the side of caution. So unconscious patients should be moved as a unit. Most common airway obstruction is the tongue. So the tongue falls backwards and blocks the airway. Other causes of airway obstruction: dentures, false teeth, blood, vomitus, mucus, food, other foreign objects. So we did this last week. Remember, we use a suction unit. So if you can't see the back of the airway, what are we going to do? We're going to suction, right? For how long are we going to suction for? For an adult. No more than 10 seconds. Correct? And we're going to enter in the mouth without suction on. Once we're in the mouth, then we turn the suction on. So head tilt chin lift maneuver will open the airway in most patients. For patients who have not sustained or not suspected of having sustained trauma. So if you don't think it's trauma, you can do head tilt chin lift. So this is an example right here, and the picture shows you. So one hand on the forehead and one hand below the chin. Follow these steps with the patient supine. Position yourself beside the patient's head. Place the heel of one hand on the forehead and apply firm backward pressure with the palm. Place the fingertips of the other hand under the lower jaw. Lift the chin up with the entire lower jaw. Jaw thrust maneuver. If you suspect a cervical spine injury, use this maneuver. Follow these steps. Kneel above the patient's head. Place your fingers behind the angles of the lower jaw. Move the jaw upward. Use your thumbs to help position the jaw. Once the airway has been opened, look at the chest and observe for movement. With complete airway obstruction, there will be no movement of air. Chest wall movement alone does not indicate that breathing is adequate. Even if the airway is opened, the mouth may be closed. For the cross finger technique, place the tips of your index finger and the thumb on the patient's teeth. Push your thumb on the lower teeth. Push your index finger on the upper teeth. The index finger and the thumb cross over each other. So it's an example of jaw thrust. So if you think the patient may be having a traumatic injury, or if you're unsure, you want to err on the side of caution. So you're going to do jaw thrust to open the airway. So suctioning. You must keep the airway clear to ventilate properly. Portable, hand-operated, and fixated equipment is essential for resuscitation. So when you're working, you're going to have most likely two suctions. You're going to have one in the wall, and then you're going to have a portable right here. This is what we carry, this little red bag right here. So anytime we have a respiratory call or we have a full arrest, we're going to bring this on to make sure we clear the airway so we could stick an OPA in. A portable or fixed unit should have wide-bore, thick-walled, non-kinking tube, plastic rigid pharyngeal suction cups, non-rigid plastic catheters, non-breakable disposable collection bottle, water supply for rinsing the tips. So techniques of suctioning. Inspect the equipment regularly. To operate the suction unit, check the unit for proper assembly of its parts. So before you get anything, so every time we come in to work, we're checking the equipment every single day. No matter if we were the last person to use it or not. We want to make sure everything's working that day. So you want to check the unit, make sure all the parts are assembled right. Test the suction unit to ensure vacuum pressure more than 300 millimeters of mercury. Select and attach the appropriate suction catheter to the tubing. So what's a hard suction catheter called? A Yankauer. And what's a soft suction catheter? It's going to be a French. Never suction the mouth or nose for more than 15 seconds at one time for adult patients, 10 seconds for children, and 5 seconds for infants. Suctioning can result in hypoxia. When patients have secretions or vomitus that cannot be suctioned easily, remove the catheter from the patient's mouth, log roll the patient to the side, clear the mouth carefully with a gloved finger. If the patient produces frothy secretions as quickly as you could suction them, suction the airway for 15 seconds, less in infants and children. Ventilate for 2 minutes. Continue this alternating pattern until all secretions have been cleared. So basic airway adjuncts. Prevent obstruction by the tongue and allow for passage of air and oxygen to the lungs. Oropharyngeal airways. Keep the tongue from blocking the upper airway. Make it easier to suction the oropharynx if necessary. Indications: unresponsive patients without a gag reflex. Apneic patients being ventilated with a bag valve mask. Contraindications. Conscious patients, any patient who has an intact gag reflex. Nasopharyngeal airways. Indications. Patient who is unresponsive who has an altered LOC. Patient who has an intact gag reflex. Patient who is unable to maintain his or her own airway spontaneously. Semi-conscious or unconscious patients with an intact gag reflex. Patients who will not tolerate an OPA airway. Contraindications. Severe head injury with blood in the nose. History of fractured nasal bone. So, recovery position. Used to help maintain a clear airway in an unconscious patient who is not injured and is breathing on his or her own. So you want to lay them on their side. Have the side that they're laying on, their arm up, and then the other hand underneath their head. In case if they throw up, the blood's going to come out. It's not going to stay in the airway. It's not going to go back down. They're going to aspirate and get it back in their own lungs and possibly choke on it. Take the following steps. Roll the patient onto either side so that the head, shoulder, and torso move at the same time without twisting. Extend the patient's lower arm and place the upper hand under his or her cheek. Not appropriate for patients with suspected spinal injuries. Supplemental oxygen. Always give oxygen to patients who are hypoxic. Some tissues and organs need a constant supply of oxygen to function normally. Never withhold oxygen from any patient who might benefit from it. Supplemental oxygen equipment. Become familiar with how oxygen is stored. Oxygen cylinders contain compressed gas. Liquid oxygen is becoming a more commonly used alternative. Safety considerations. Handle gas cylinders carefully. Make sure the correct pressure regulator is firmly attached before transport. A puncture hole in a tank can turn it into a deadly missile. Secure cylinders when stored on an ambulance and when in use during transport. Pin indexing system. Prevents such mistakes as an oxygen regulator being accidentally connected to a carbon dioxide cylinder. Every cylinder of a specific gas type has a given pattern and a given number of pins. Pressure regulators. Reduce the cylinder's pressure to a useful therapeutic range, usually 40 to 70 psi. Final attachment for delivering the gas is either a quick connect female fitting or a flow meter. Flow meters. Usually permanently attached to pressure regulators on emergency medical equipment. Pressure compensated flow meter. Bourdon gauge flow meter. Hazardous supplemental oxygen. Combustion, oxygen toxicity. So that's why we never smoke near oxygen tanks, because it could start a fire. Combustion, oxygen does not burn or explode, but does speed up the combustion process. Keep any sources of fire away. Make sure the area is adequately ventilated. Never leave an oxygen cylinder standing unattended. So, I don't know if you guys noticed when I did skills on Saturday, I laid the oxygen container on the ground because that thing could turn into a missile if we drop it. So always keep the cylinder on the ground, on its side, unless you're standing right next to it and you're holding it. Oxygen toxicity. Not all patients need high concentrations of oxygen. Oxygen can have detrimental effects in patients with certain illnesses, COPD. When pulse oximetry is available, tailor oxygen therapy. Administer the minimum amount necessary to maintain oxygen saturation at or above 94%. So people with COPD are going to have lower oxygen saturations. They might sat in the low 90s or high 80s, but that might be normal for them. But if they're complaining of difficulty breathing, you should give them oxygen. Oxygen delivery equipment. Non-rebreathing mask, bag valve mask, nasal cannulas. Non-rebreathing mask. Preferred way to give oxygen in the pre-hospital setting to patients who are breathing adequately but are suspected of having hypoxia. Combination mask and a reservoir bag system. So non-rebreather. You're gonna have your oxygen tubing, you're gonna have your mask, and you're gonna have your reservoir bag system. So you're gonna turn the O2 tank to about 10 to 15, and once it's on, you're gonna make sure that this bag is inflated before you put it on the patient. And then you're gonna put the strap around the head and pull the string to make sure it's on tightly. Make sure the reservoir bag is full before placing the mask on the patient. Adjust the flow rate so the bag does not collapse when the patient inhales. Usually about 10 to 15 liters a minute. When oxygen therapy is discontinued, remove the mask. Deliver oxygen through two small tube-like prongs that fit into the nostrils. Can provide 24 to 44% inspired oxygen when the flow meter is set at 1 to 6 liters per minute. So it's kind of hard to see, but you have two little prongs. Make sure they're facing up and in towards the patient when you put them in. 1 to 6 liters per minute is the max. I wouldn't go any more. It's going to feel really uncomfortable if you go more than 6 liters a minute on a cannula if you give it to somebody. When you anticipate a long transport time, consider using humidification. So what happens is it dries out your nasal cavity if you give them oxygen for too long. It's limited use in the pre-hospital setting. A patient who breathes through the mouth or has a nasal obstruction will not benefit. Always try to give high flow oxygen through a non-rebreathing mask. So anytime you're going to give more than 6 liters per minute, put them on a non-rebreather. Partial rebreathing mask. Similar to a non-rebreathing mask, there is no one-way valve between the mask and the reservoir. Patients rebreathe a small amount of exhaled air. Advantage if patient is hyperventilating. Venturi mask. The number of settings can vary the percentage of oxygen while constant flow is maintained, accomplished by the Venturi principle. Medium flow devices that deliver 24 to 40% oxygen, useful in long-term management of physiologically stable patients. Tracheostomy mask. Patients with tracheostomies do not breathe through their mouth and nose. So they're going to have a hole in their throat, a hole in their trachea basically, and that's where they breathe through. So if patient has low O2 saturations, you give them a non-rebreather right over the mask. Or if they're having respiratory failure, respiratory arrest, you could take the mask off the BVM and it'll attach right onto there, and you could bag them through the trachea. Tracheostomy mask cover the tracheostomy hole and have a strap that goes around the neck. May not be available in an emergency setting, improvised by using a face mask instead, placed at the tracheostomy opening. Humidification. Some EMS systems provide humidified oxygen. During extended transport, many EMS systems do not use humidified oxygen in the pre-hospital setting for certain conditions such as croup. Dry oxygen is not considered harmful for short-term use. So in this county, we don't carry humidified oxygen. Our transport times are way too short. But in other states where you're going to have longer transport times, they're going to carry. Assisted and artificial ventilation, probably the most important skills in EMS at any level. Basic airway and ventilation techniques are extremely effective. Follow standard precautions as needed when managing a patient's airway. Assisting ventilation and respiratory distress failure. Intervene quickly to prevent further deterioration. 2 treatment options: assisted ventilation and CPAP. So Anna says that you guys are able to do CPAP now. So that's something we'll have to go over. Assisted ventilation, we've kind of already gone over that with the BVM. Signs and symptoms of inadequate ventilation: altered mental status, inadequate minute volume, excessive accessory muscle use, and fatigue. When assisting with the BVM, explain the procedure to the patient. So every time you're doing something, you need to explain what you're doing to the patient so they understand. Place a mask over the nose and mouth. Squeeze the bag each time the patient breathes. After the initial 5 to 10 breaths, deliver an appropriate tidal volume. Maintain an adequate minute volume. Remember, you're assisting with the BVM. Artificial ventilation. Patients in respiratory arrest need immediate treatment to live. Once a patient is not breathing, begin artificial ventilation immediately via mouth-to-mask technique, 1 or 2 person BVM, manually triggered ventilation device. Normal ventilation versus positive pressure ventilation. In normal ventilation, the diaphragm contracts and negative pressure is generated in the chest cavity. So it's like a vacuum. It's sucking in air when the diaphragm contracts. Positive pressure ventilation generated by a device such as BVM that forces air into the chest cavity. Remember, you're ventilating. So it's an artificial ventilation device. With positive pressure ventilation, increased intrathoracic pressure reduces the blood pump by the heart. More volume is required to have the same effects as normal breathing. Air is forced into the stomach, causing gastric distension. So you guys have to be careful. If you guys give breaths way too fast, or if it's too forceful, it causes air to go into the stomach. And you could actually see their stomach getting bigger because you're pumping so much air in there. Mouth-to-mouth and mouth-to-mask ventilation. Barrier device is routinely used in mouth-to-mouth ventilations. Mask with an oxygen inlet provides oxygen during mouth-to-mask ventilation. Signs of inadequate ventilations. Patient's color improves. Chest rises adequately. Remember, equal chest rise and fall. No resistance when ventilating. You hear and feel air escape as the patient exhales. Bag valve mask. So remember, we carry these. This is going to be your mask, your BVM, your reservoir, and then your oxygen tubing is going to be connected to an oxygen tank over here. So when you're ventilating with the BVM, you're going to ventilate at 15 liters per minute. Most common method to use to ventilate patients in the field. Provides less tidal volume than mouth-to-mask ventilation. An experienced EMT can provide adequate tidal volume. If you have difficulty ventilating with BVM, switch to another method. Or try readjust their airway. The volume of oxygen is based on observing chest rise and fall. Whenever possible, work with your partner to provide BVM ventilation. Gastric distension occurs when artificial ventilation fills the stomach with air. Most commonly affects children. Most likely to occur when you ventilate the patient too forcefully or too rapidly. May also occur when the airway is obstructed. So when you're ventilating, remember, relax. Every 5 to 6 seconds for an adult, you're going to breathe 1 time, and every 3 to 5 seconds for a child, you're going to breathe once. And pay attention when you're ventilating and you're watching the chest rise and fall. So to prevent or alleviate distension, ensure the patient's airway is appropriately positioned. Ventilate at the appropriate rate. Ventilate with appropriate volume. If the stomach appears distended, recheck and reposition the head and perform rescue breathing. So remember, you can reposition the head, reposition the airway. Passive ventilation. Expansion and contraction create a pump for air movement. Benefits patients who are receiving chest compressions. Can be enhanced using oropharyngeal airway and supplemental oxygen. Manually triggered ventilation devices, also known as flow-restricted, oxygen-powered ventilation devices, allow a single rescuer to use both hands to maintain the mask-to-face seal while providing positive pressure ventilation. Reduces rescuer fatigue. May be difficult to maintain adequate ventilation without assistance. Should not be used routinely. Should not be used in patients with COPD or suspected cervical spine or chest injuries. So, automatic transport ventilator resuscitator. A manually triggered device attached to a control box. Allows the variables of ventilation to be set. Lacks a sophisticated control of a hospital ventilator, frees the EMT to perform other tasks. So CPAP. So this is a great one for people with CHF. It's gonna be a full, I don't want to say a full mask, but it's gonna go all the way over the head. So you got 2 straps up here and 2 straps down below, and then this tubing is gonna be connected to your airway, or excuse me, to your oxygen tank. So you have to make sure these straps are tight. You got to make sure there's no leaks. The CPAP machine uses a lot of air, a lot of O2 really fast. So if you're on your D tank, the small portable tanks, you got to make sure you have enough, and you got to make sure you get them in the ambulance and switch them over. I use about 25 liters a minute. So non-invasive ventilatory support for respiratory distress. Many people diagnosed with obstructive sleep apnea wear a CPAP at night, becoming widely used at the EMT level. Mechanism: increases pressure in the lungs, opens collapsed alveoli, perhaps pushes more oxygen across the alveolar membrane, forces interstitial fluid back into the pulmonary circulation. So if a patient is suffering from CHF, they have fluid in the lungs, it's going to force that interstitial fluid back into the pulmonary circulation, and it's going to get rid of that fluid in their lungs, make it easier for them to breathe. So mechanism: therapy is delivered through a face mask held to the head with a strapping system. Use caution with patients with potentially low blood pressure. So contraindication for this is, in this county, it's going to be systolic of 100. So if a patient has a blood pressure over 100, we could use a CPAP. If it's under 100, we got to do BVM. Indications: so any of these right here, we could use CPAP for. Patient's alert and able to follow commands. Patient displays obvious signs of moderate to severe respiratory distress. Patient is breathing rapidly. Pulse oximetry reading is less than 90%. So all these things do not have to be here for you to use CPAP. If you believe a patient's going to improve by using CPAP, then you can go ahead and try it. Okay, so contraindications. Patient has to be at least breathing on their own. They cannot be in respiratory arrest because the CPAP will not work. Signs and symptoms of pneumothorax or chest trauma. Patient who has tracheostomy. Active gastrointestinal bleeding or vomiting. Patient who is unable to follow verbal commands. Application: resistance creates back pressure that pushes open smaller airway structures as the patient exhales. 7 to 10 centimeters H2O is acceptable. So that there's a little dial on the CPAP on the front, and that's what you want to put it in between, 7 to 10. We do 7.5 in this county. Complications: some patients may find CPAP claustrophobic. It's very weird to have something strapped onto your head very tightly, and it's a small mask. And especially when people are having difficulty breathing, it could cause them to be claustrophobic. Risk of pneumothorax: can lower the patient's blood pressure. If the patient shows signs of deterioration, remove CPAP and begin positive pressure ventilation using a BVM. So remember, if patient's blood pressure is lower than 100, we use positive pressure ventilation. If the patient deteriorates, remove the CPAP and begin positive pressure ventilation. So this is a picture of tracheostomy, the front of the airway. Stomas and tracheostomy tubes. Patients who have had a laryngectomy have a permanent tracheal stoma, known as tracheostomy. Neither the head tilt chin lift maneuver nor the jaw thrust maneuver is required. If the patient has a tracheostomy tube, ventilate through the tube with a BVM. So remember, take the mask off, and you can ventilate straight from the BVM to their tracheostomy tube. If the patient has a stoma but no tube is in place, use an infant or child mask with your BVM to make a seal over the stoma. So remember I talked about on C-collars, right? If it's too big on an adult, what can you use on there? You don't want their neck bouncing around if you think of possible spinal injury. You go down, you use a pediatric C-collar. So this is the same thing. You use an infant or child mask to make the seal over the stoma if there is no tube in place already. So foreign body airway obstruction. If a foreign body completely blocks the airway, it is a true emergency. It will result in death if not treated immediately. An adult usually occurs during a meal, and a child can occur while eating, playing with small toys, or crawling. So everyone look at your finger. Look at your pinky finger. Look how big it is. Now, remember a kid, a small baby. Think about how tiny their hands are. Think about how tiny their pinky is. That's how big their airway is. That's why it's important to always watch kids and not give them any small toys and any big food, because it's going to get stuck in their airway and it's going to get hard for them to get it out. The tongue is the most common airway obstruction in an unconscious patient. This is probably going to be a test question. So remember that. The tongue is the most common airway obstruction in an unconscious patient. Causes of airway obstruction that do not involve foreign bodies: swelling from infection or acute allergic reaction, trauma, tissue damage from injury. Early recognition is crucial. Mild airway obstruction. Patients can still exchange air but will have respiratory distress. Noisy breathing, wheezing, coughing. With good air exchange, do not interfere with the patient's efforts to expel the object on his or her own. So if a patient is actively coughing and can speak, do not interfere with the patient's efforts to expel the object. If you do, this may worsen the situation. It might cause the object to go further down into their throat and cause a full airway obstruction. A mild airway obstruction. With poor air exchange, the patient may have increased difficulty breathing, stridor, and cyanosis. Treat immediately. If the patient is having difficulty breathing and you hear stridor or you see cyanosis, you could try the Heimlich maneuver. That's not a good sign right there when he's grabbing his throat. Severe airway obstruction. Patients cannot breathe, talk, or cough. Patient may use the universal distress signal. Universal distress signal. Begin to turn cyanotic and have extreme difficulty breathing. Provide immediate treatment to the conscious patient. If not treated, the patient will become unconscious and die. The patient is unresponsive, not breathing, and has no pulse. Begin CPR with chest compressions. So, emergency medical care for foreign body airway obstruction. Perform a head tilt chin lift maneuver to clear a tongue obstruction. Large obstructions should be swept forward out of the mouth with your gloved index finger. Abdominal thrusts are the most effective method of dislodging and forcing out an object. So, do not do a blind finger sweep. If you could see something in the airway, you could do a finger sweep. If not, don't do it. You might push the object further down. Dental appliances can cause an airway obstruction. Examples: crown, bridge, dentures, piece of braces. Manually remove the appliance before providing ventilations. Leave well-fitting dentures in place. Loose dentures interfere with the process and should be removed. Facial bleeding. Airway problems can be particularly challenging in patients with serious facial bleeding. The blood supply to the face is very rich. Injuries can result in severe tissue swelling and bleeding into the airway. Control bleeding with direct pressure and suction as necessary. So, review. Breathing is controlled by an area in the B. The pons and the medulla are the respiratory centers in the brainstem that control breathing. The lungs contain small pockets called alveoli where the exchange of oxygen and carbon dioxide takes place. So that's respiration, right? Spinal cord. Pulses are sent down the spinal cord from the brainstem. And the diaphragm receives the impulses that cause it to contract and bring the air in. The EMT should assess a patient's tidal volume by A. Tidal volume. The volume of air that is moved into or out of the lungs in a single breath is assessed by observing for adequate chest rise. If shallow chest rise is noted, the patient's tidal volume is likely reduced. So when you're given BVM, when you're given assisted ventilations, you're looking for equal chest rise and fall. You're making sure that the chest rises. You're going to get good tidal volume. So counting the patient's respiratory rate. Counting the respiratory rate gives you the minute volume. And then patient's oxygen saturation. Oxygen saturation is indication of tissue perfusion. In an otherwise healthy individual, the primary stimulus to breathe is a in a healthy individual, do you think it's going to be a decreased level of oxygen or an increased level of carbon dioxide in the blood? Okay. Under control of the brainstem, rising levels of carbon dioxide in arterial blood normally stimulate breathing in an otherwise healthy patient. Signs of adequate breathing in an adult include all the following except. So remember, read the question carefully. What's the key word in the question? Or what are the two keywords? Signs of adequate. So what does adequate breathing mean? Do all these contain adequate except what? Pink, warm, dry skin. That's adequate. Symmetrical. So moving as one. Chest movement. So equal chest rise and fall. What's your normal respiratory rate as an adult? 12 to 20 breaths a minute. So respiratory rate of 16 breaths a minute. Anytime you see shallow or labored, that's a sign of inadequate breathing. Signs of inadequate breathing in an adult include a respiratory rate less than 12 breaths a minute or greater than 20 breaths a minute, shallow chest rise, reduced tidal volume, cyanosis, and asymmetrical chest movement. Both sides of the chest do not move equally. During insertion of an oropharyngeal airway into an unconscious patient, she begins to vomit. The first thing you should do is you could probably do all these things to improve her condition, but what's the first thing you should do? So whenever an unconscious patient begins to vomit, whether you're inserting an oropharyngeal airway or not, you should immediately turn the patient onto his or her side. This will allow drainage of vomit from the mouth, prevent aspiration. After the patient is on his or her side, remove the oral airway and suction the mouth. So what position is this called? It's called the recovery position. In which of the following patients would a nasopharyngeal airway be contraindicated? So you try and stick an OPA in somebody and gags when you insert an oral airway. So they have a gag reflex, so you're not going to be able to do that. You could do an MPA on this one. An unconscious patient with an intact gag reflex. Same thing. You're not going to stick an OPA in somebody with a gag reflex. Semi-conscious patient with a gag reflex. Not going to do that one. Anybody with a traumatic head injury or possible nosebleed, you're not going to stick an MPA in. So this would be contraindicated, right? So C, nasopharyngeal airways are contraindicated in patients with severe head or facial injuries and should be used with caution in patients who have delicate nasal membranes or are prone to nosebleeds. The nasal airway is better tolerated in patients who are semi-conscious and or those with a gag reflex. You are delivering oxygen to a patient with a nasal cannula at 4 liters a minute. When he begins to complain of a burning sensation in his nose, you should. So we don't carry it in this county, but what can you do for a patient who's on a nasal cannula? Because remember, it could dry out the nasal cavities. You can remove the nasal cannula. You can apply a non-rebreathing mask. I would not increase the flow rate to 6 liters a minute if he's already complaining of burning sensation in his nose. You should attach an oxygen humidifier. C. Administering dry oxygen through nasal cannula, especially over a prolonged period of time, can result in drying of the nasal membranes, in which case the patient might complain of a burning sensation in the nose. Humidified oxygen will serve to keep the nasal membranes moist. The patient is found unconscious after falling from a third-floor window. His respirations are slow and irregular. You should... Is this adequate breathing right now? Is slow and irregular adequate breathing? So remember, look for the keywords in every question. Patient's unconscious. His respirations are slow and irregular. Probably not going to put somebody in the recovery position. That's a trauma. He doesn't have adequate breathing, so I wouldn't put a non-rebreather on his mask. Suction his airway for up to 15 seconds. Do you see anywhere in here where it says patient has any secretions or is vomiting, any blood? Okay, so you're going to assist his breathing with the bag mask device. So D, the patient is not breathing adequately. Slow, irregular respirations will not result in adequate oxygenation. You should assist the patient's breathing with the bag valve mask attached to 100% oxygen. Suctioning is indicated if the patient has blood or other liquids in the airway. There's no evidence in this scenario. So remember, suctioning is indicated if the patient has blood or other liquids in the airway. Well, when ventilating an apneic adult with a bag valve mask, you should squeeze the bag. So D, when ventilating any apneic patient with a bag valve mask, you should squeeze the bag over a period of 1 second and observe for visible chest rise. Ventilating the apneic adult at a rate of 10 to 12 breaths a minute, 1 breath every 5 seconds. So remember, ventilating 1 breath every 5 to 6 seconds for an adult. Ventilate infants and children at a rate of 12 to 20 breaths a minute, 1 breath every 3 to 5 seconds, or 1 breath every 3 seconds. So remember those numbers. You and your partner are ventilating an apneic adult when you notice that his stomach is becoming distended. You should So does it say anywhere in here where it says any secretions in the airway? No. So you're not going to suction his airway. If his stomach is being distended, what's the reason for that? Are you giving too forceful or too rapid ventilations? Most likely. So you're not going to increase the rate even more, increase the rate and volume of your ventilations. And you're not going to decrease your ventilation. Well, you're probably going to decrease your ventilation rate, but you're not going to use more volume. You're going to reposition his head, reposition the airway, right? So B, gastric distension occurs when air enters the stomach. Severe gastric distension can result in vomiting and aspiration if not recognized and treated. To minimize the amount of air that enters the stomach during ventilations, you should reposition the patient's head.